continuing with stomach. We'll start with anatomy of stomach. So what are the parts of the stomach? We all know there are four parts of stomach mainly, that is cardia, then fundus, then body, antrum, and this the ending part of the stomach is pylorus. So basically cardia, fundus, body of the stomach, antrum, and pylorus. These are the parts of the stomach. What do we know about cardia? Basically we'll be saying related to pathology only. So cardia, why should we know about cardia? It is the most common site for Mallory-Weiss syndrome and Burkitt's lymphoma. We all know about Burkitt's lymphoma. It is a tumor of lymph nodes, or basically WBCs. Okay, what is Mallory-Weiss syndrome now? It is basically seen in alcoholics who consume too much of alcohol and usually vomit stuffs. Okay, so during this there will be forceful vomiting, and because of which there will be a tear in the esophagus also. So it's like because of forceful vomiting there will be tear in the mucosa of cardiac region of stomach and esophagus. Okay, so this syndrome is called as Mallory-Weiss syndrome, usually seen in alcoholics. Okay, now why do we need to know about the fundus? It is the most common site of stress ulcers and stress gastritis. Okay, and most common site for carcinoma of stomach in case of pernicious anemia. So if a patient is suffering from pernicious anemia, that is due to deficiency of intrinsic factor vitamin, that is intrinsic factor, because of which there will be deficiency of or decreased absorption of vitamin B12, and this leads to anemia, and this is called as pernicious anemia. In this case, if this person undergoes CS stomach, carcinoma of stomach, if the tumor starts growing in the stomach, it will usually start from this fundus region. In case of pernicious anemia, it is the most common site of CS stomach, and it is most common site for diffuse variety of CS stomach also. There are two types of or two varieties of CS stomach, basically diffuse variety and intestinal variety. So in that, diffuse variety is most common here. Okay, so what do we need to know about the body of the stomach? It is the most common site, gastric site of gastric pacemaker cells, that is also known as interstitial cells of Kahal. Okay, so ಈ ಬಾಡಿಯಲ್ಲಿ just like pacemaker cells are there in stomach, that is SA node, which carries out, which is myogenic, it serves on its own. Similarly, there are certain cells in stomach, they are located in this body of the stomach, and they are called interstitial cells of Kahal. Okay, these are pacemaker cells. This help in ಏನಕ್ಕೆ ಬೇಕು ಇದು ಇಂಟರ್ಸ್ಟಿಷಿಯಲ್ ಸೆಲ್ಸ್ ಪೇಸ್ಮೇಕರ್ ಸೆಲ್ಸ್ ಏನಕ್ಕೆ ಬೇಕು? ಟು ಕ್ಯಾರಿ ಔಟ್ peristalsis. Okay, so these interstitial cells of Kahal are located in body of the stomach. So if there are procedures in which we'll go for gastrectomy and all, like we'll remove the stomach, we'll remove a part of the stomach like this. If the body of the stomach is removed, then these cells will be removed, which means we are hampering peristalsis. Okay, for that reason we need to know about this interstitial cells of Kahal. Okay, so these gastric pacemaker cells are located in the mid body along the greater curvature. So we all know this is the one I am marking in green is the greater curvature, and the one I am marking in pink is the lesser curvature. Okay, so here this interstitial cells of Kahal are located here in the mid body along the greater curvature. Okay, so what do we need to know about the antrum of the stomach? It is the most common site for carcinoma of stomach overall, that is this region. Okay, most common site for CS stomach overall, and it is also the most common site for gastric lymphoma. So hence antrum is most important because we need to study about CS stomach. So what is incisura angularis? It is the notch near the longer curvature. Okay, or actually it is lesser curvature, I don't know why they have written it like longer curvature. Whatever the notch we are seeing here, this notch along the lesser curvature is called as incisura angularis, and this site is most common site for gastric ulcer. Okay. So after knowing about the parts of the stomach, we need to know about the nerve relation with stomach. Okay. So what do we know here is, suppose this is lesser curvature, and this is greater curvature. Okay. So this becomes the anterior part and this becomes the posterior part. Along the lesser curvature is the anterior part and along the greater curvature is the posterior part. That we need to know. And here left vagus is anterior. So whatever the nerve is coming from here, this is left vagus and it is anterior. Whatever the nerve is coming here, this is right vagus and this is posterior. Okay, so basically we need to know vagus and its relation with stomach. Okay, so now left vagus gives a branch called as hepatic branch. Here, this will go to the liver. Okay, so this is hepatic branch, and there are many seromuscular branches. Okay, so what branches do this right vagus give? It gives criminal nerve of Grassi, which is the first branch, celiac branches, and seromuscular branches. Better to show it in this figure. So here this is left vagus, right? And it gives the first branch, that is hepatic branch, and many seromuscular branches are there. And then it will come till the pylorus. And there it gives numerous ending or numerous branches which appear like a crow's foot. This is called as pes anserinus. Important ಯಾಕೆ ಅಂತ ಆಮೇಲೆ ಗೊತ್ತಾಗುತ್ತೆ, just follow up with me. Okay, so here I am speaking about left vagus, which is the anterior relation of the stomach, which gives first branch, that is hepatic branch, and then it comes and provides many seromuscular branches, and it is ending in crow's foot, that is pes anserinus, and that nerve is called as nerve of lateral jet. Okay, and then there is right vagus, which gives criminal nerve of Grassi, that is the first branch, then celiac branch. So this is right vagus. Okay, this gives first branch, that is criminal nerve of Grassi, which is supplying almost the cardia of the stomach. Then it comes down and gives many celiac branches, and then many seromuscular branches, and ends here. Okay, so basically it is like I wrote like this in order to help you out. Okay, so this is hepatic branch, here this is celiac branch, and then many seromuscular branches, and then it will end here, whereas the left vagus will end near the antrum or near the pylorus in nerve of lateral jet. Okay, so these two relations, basically anteriorly we have left vagus and its branches, posteriorly we have right vagus and its branches. If we know this much, we are good. Okay, so now why did we discuss all this? There are procedures called vagotomy, in which we will be cutting this vagus nerve in order to treat certain conditions. So what are the types of vagotomy do we know? First type is highly selective vagotomy. In this, what we will do, we will just cut the seromuscular branches with preserved supply of pylorus. Only these branches, whichever is supplying the stomach, these seromuscular branches will be cut. So what is the main function of vagus? Vagus is parasympathetic, right? What does the parasympathetic nerve system do for peristalsis? It increases peristalsis. Okay, na? So if we have to reduce peristalsis or if we have to decrease peristalsis, then we will have to inhibit this vagus. In order to inhibit this vagus, we will cut certain branches, and one such procedure is highly selective vagotomy, in which we will cut only the seromuscular branches of vagus. Here nerve of lateral jet is intact, hence pylorus has its nerve supply intact. whereas only the stomach, whatever the cardia, antrum, body up to antrum, nerve supply is cut off. Okay, so this is what we'll do in certain procedures. You just remember the procedure, we'll come to know where we'll do what. Okay, then selective vagotomy, in which division of vagus after celiac and hepatic branch is cut off. So if it is highly selective vagotomy, we'll do only seromuscular branches. If it is selective vagotomy, after this division, we'll just remove whatever the branches we get. After hepatic and celiac, everything else of the vagus nerve is cut off. Okay, so truncal vagotomy means division of main trunk of the vagus. That means even before it gives all these branches only, we are cutting off the vagus. Okay, basically this will help us in management of CS stomach and all, up to where the tumor has progressed and up to what level we will have to cut off the nerve supply. For that reason we are studying all this. Okay, this is just a build up so that while studying carcinoma of stomach, we will not be wondering why vagotomy is a treatment for carcinoma of stomach. Okay, so this was about types of vagotomy: highly selective vagotomy and truncal vagotomy. Now we'll start with proper pathologies of stomach, that is gastric and duodenal ulcer, which in turn can be called as peptic ulcer. Okay, so gastric and duodenal ulcer, why do they occur? Because of increased acid production, HCl. Okay, for healing to occur, vagotomy has to be performed. Maybe this can be said as why did we study about vagotomy? So in order to treat gastric and duodenal ulcer, vagotomy is a procedure. Okay, if there is an intractable duodenal ulcer, I mean even after treating with proton pump inhibitors or with antacids, if the ulcer is not healing, then that ulcer is called as intractable duodenal ulcer. For that, what we need to do, we'll have to go for high selective vagotomy. So how can we treat, like how will the vagotomy be treatment for this is, just like we have discussed, along with decreasing peristalsis, it will decrease HCl production. Hence, if we cut off vagus, then there will be decreased acid production. What was the pathology we knew for causing gastric and duodenal ulcer? It was because of increased acid production. If we go for vagotomy, it will reduce the acid production and hence we are treating the cause. Okay. Similarly, recurrent duodenal ulcer, treatment of choice is truncal vagotomy. If even after high selective vagotomy or even after doing everything for the treatment of ulcer, if it is recurring, then the only possibility is go for truncal vagotomy, remove entire vagus nerve supply only, so that acid production will be reduced. Okay, so now we will be dealing with the main pathology, that is peptic ulcer. Yeah, peptic ulcer is of two types based on the location. So it can be anywhere in the stomach called gastric ulcer, or it can be in the duodenum called as duodenal ulcer. Okay, so both of these are combinedly called as peptic ulcer. Okay, what is the main pathologies? Helicobacter pylori. It is a bacteria which is responsible for about 90% cases of duodenal ulcer and 75% cases of gastric ulcer. So this is the main culprit. Other than that, what is the most common type of peptic ulcer is duodenal is most common, and it is usually most common in the first part of the duodenum. Okay. So treatment for gastric ulcer depends on the location and type, and treatment for duodenal ulcer depends on complication. So this we need to know. Treatment depends on complications, whereas gastric ulcer treatment depends on location. Okay, so now we'll start with gastric ulcers first. How do we classify gastric ulcers? According to modified Johnson's classification, if the ulcer is located at incisura angularis, we had studied it is the notch present along the lesser curvature, and it is the most common site for gastric ulcers. So this is incisura angularis. Hence, if the ulcer is found in the most common location, it is type 1. Okay, type 2, there can be two ulcers, one in the body of the stomach and one at the first part of the duodenum. So this is type 2, one in the body of the stomach and one in the first part of the duodenum. If this is, if there are two ulcers, one in body and one in duodenum, then that is type 2. This type 3 is also called as pre-pyloric ulcer. Just before the pylorus there is an ulcer. So this is pylorus and pre-pyloric ulcer. This is type 3. What is type 4? Ulcer located on the lesser curvature anywhere except at incisura angularis, anywhere along the lesser curvature, it is type 4. So if the ulcer which has been happening here, it is because of use of NSAIDs, non-steroidal anti-inflammatory drugs, then it is classified under type 5. Okay. So what do we need to know about these types? Type 1 is usually associated with blood group A people. Type 2 to type 4 is associated with blood group O people. And in type 1, 4 and 5, that is 1, 4 and 5, acid production is either normal or low, but still ulcer is happening here. Hence, vagotomy is of no use, because we will do vagotomy in order to reduce the acid production. And since here in types 1, 2, 1, 4 and 5, the acid production is either normal or low, vagotomy is of no use. Whereas in type 2 and 3, there will be increased acid production and truncal vagotomy routinely is performed. Okay. Okay. So now, how do we manage these gastric ulcers? For type 1, that is ulcer at the incisura angularis, we will perform distal gastrectomy. What is distal gastrectomy? We will remove the distal part of the stomach. So distal part of the stomach is removed. Ulcer was here in the incisura angularis. Okay. So if distal part of the stomach is removed, ulcer will also be removed and it is cured. So distal gastrectomy is the type management for type 1. For type 2 and 3, there are two ulcers, and in type 3 there is pre-pyloric ulcer. During that case, we will go for truncal vagotomy, because in type 2 and 3 there is increased acid production, just like I have mentioned before. For that reason, we will go for truncal vagotomy, and then removal of antrum of the stomach, that is antrectomy. Why are we removing antrum? Starting ಅಲ್ಲಿ ನೋಡಿದ್ವಲ್ಲ, antrum ಅಲ್ಲಿ ಏನು most common? It is the most common site for CS stomach and gastric lymphoma. So these ulcers can in turn cause CS stomach also. For that reason, we are going for truncal vagotomy and antrectomy. Okay. Type 4, there are special surgeries for type 4. That is Sanders procedure, Pauchet procedure, Kelling-Madlener and Shoemaker procedures. So we will be discussing about this. Okay. So type 5, it is because of NSAIDs, so we have to stop NSAIDs. So this is the management of gastric ulcers. So based on location, we have studied. Okay. Now, just like we know, complications of peptic ulcers is important, because we manage peptic ulcer based on the complications. First one is intractability. Okay. So idralli not healing even after medical management. Then it is called as intractable duodenal ulcer. Okay. So next complication ಏನಾಗಬಹುದು? There can be bleeding from this peptic ulcer, which is the most common complication. Then there can be a perforation. Usually this will happen in case of gastric ulcers, but if it can also happen in peptic ulcers also. And the fourth and deadly complication is gastric outlet obstruction can happen. Okay. So how will we treat peptic ulcers? First one, we will go for high selective vagotomy, and this is performed in cases of intractable duodenal ulcer or chronic duodenal ulcer. So we need to know certain points related to peptic ulcers. If the ulcers are located on the anterior wall of the abdomen, they'll usually perforate, whereas ulcers which are located on the posterior wall of the abdomen, they'll bleed. So This ulcer is located in the anterior wall and it will usually perforate. Okay, the posterior wall, whichever ulcer is there, it will usually bleed. And the most common artery involved in bleeding duodenal ulcer is gastroduodenal artery. Gastroduodenal artery. And since it is supplying from the posterior part, whatever the ulcer that occurs, if it is in the posterior wall of the duodenum, then usually it will bleed, and anteriorly it will perforate. Okay, so how will we manage the bleeding duodenal ulcer? If there is a bleeding duodenal ulcer, we'll go for opening of the duodenum, that is duodenotomy, and we'll see the blood vessel from where the bleed is actually happening, and we'll ligate that blood vessel, and then we'll go for truncal vagotomy to prevent rebleeding and recurrence of duodenal ulcer because of high acid production. And if there is a need, we'll go for pyloroplasty also, that is put a stent along the pylorus in order to prevent stricture formation. Okay, so this is how we manage a bleeding ulcer. First, we'll go for opening of the duodenum and check from where the bleed is actually happening and ligate that blood vessel, and then we'll have to prevent ulcer formation also, because ulcer has formed, only as a complication bleeding is happening. So now we have two conditions here. For bleeding, we'll go for duodenotomy and then ligation of the bleeding vessel. But ulcer is not treated. If we don't treat this, this will keep on happening. So in order to treat this, we'll go for truncal vagotomy and then pyloroplasty if needed. Okay. So if there is a duodenal perforation, what will we do? We'll go for modified Graham's repair, in which we'll open the abdomen, we'll see some part of the omentum and we'll patch it. So that is called as omental patch repair. Okay, this is done in case of duodenal perforation, modified Graham's repair, in which there is a duodenum and here there is a perforation opening. So we are taking a patch of omentum and we are suturing it here. This is known as modified Graham's repair, which is done for duodenal perforation. Okay, so bleeding ಆದರೆ ಆಯಿತು, perforation ಆದರೆ ಆಯಿತು. ಇಂಟ್ರಾಕ್ಟೈಬಿಲಿಟಿಗೆ ಹೇಳಿದೆ ನಾನು ಏನು ಮಾಡಬೇಕು, ಹೈ ಸೆಲೆಕ್ಟಿವ್ ವೆಗೋಟಮಿ ಮಾಡಬೇಕು. ಗ್ಯಾಸ್ಟ್ರಿಕ್ ಔಟ್ಲೆಟ್ ಅಬ್ಸ್ಟ್ರಕ್ಷನ್ ಆದರೆ ಏನು ಮಾಡ್ತೀವಿ? ಸೊ ವಾಟ್ ಡು ವಿ ಮೀನ್ ಬೈ ಗ್ಯಾಸ್ಟ್ರಿಕ್ ಔಟ್ಲೆಟ್ ಅಬ್ಸ್ಟ್ರಕ್ಷನ್? ಬೇಸಿಕಲಿ ಇನ್ಕಮಿಂಗ್ ಇಸ್ ದೇರ್, ಇನ್ಲೆಟ್ ಇಸ್ ಪೇಟೆಂಟ್, ಸ್ಟಮಕ್ಕಿಂದ ಡುಯೋಡೆನಮಿಗೆ ಫುಡ್ ಬರ್ತಾ ಇದೆ. ಬಟ್ ಹಿಯರ್ ಸಮ್ವೇರ್ ಬಿಕಾಸ್ ಆಫ್ ಅಲ್ಸರ್, ಫಸ್ಟ್ ಏನಾಗುತ್ತೆ, ಅಲ್ಸರ್ ಫಾರ್ಮೇಷನ್ ಆಗುತ್ತೆ. ಅಲ್ಸರ್ ಇಸ್ ನಥಿಂಗ್ ಬಟ್ ಅ wound over the mucosa of the stomach ಅಂದ್ಕೊಳ್ಳಿ, discontinuity of the mucosa. After this, what it can happen, there can be stricture formation or some mass can grow or whatever might happen, or clot might form. This will lead to obstruction. So whatever food is coming, it is getting obstructed here. This is called as gastric outlet obstruction. And what is the most common cause of gastric outlet obstruction worldwide? That is carcinoma of the stomach. So usually carcinoma of stomach arises from the antrum that will grow, so much big mass will be formed, and this is leading to outlet obstruction. This is the most common cause worldwide, that is CA stomach. But duodenal ulcer can also lead to gastric outlet obstruction. Okay, so how will we diagnose if there is a gastric outlet obstruction or not? We'll diagnose it through a test called saline load test. What we'll do here, we'll empty the stomach, insert Rayleigh tube. After this, through the Rayleigh tube, we'll put 750 ml of saline, that is almost 3/4 liter of saline, and place the patient in sitting position. Okay, after 30 minutes, we'll aspirate the nasogastric tube, whatever the flow, we have put 750 ml, so we'll try aspirating it. If there is residual saline of more than 400 ml, then there is gastric outlet obstruction. If there is less, then it is normal. Basically, you are seeing if the fluid whatever we have inserted through Rayleigh's tube has passed down the stomach or not. ಸೊ ಇವಾಗ 750 ml ಕೊಟ್ಟು ಅರ್ಧ ಗಂಟೆ ಆದರೂ ಇನ್ನೂ ಅವನ ಹೊಟ್ಟೆಯಲ್ಲಿ 400 ml ಗಿಂತ ಮೇಲಿದೆ ಅಂದರೆ ದಟ್ ಮೀನ್ಸ್ ಫ್ಲೂಯಿಡ್ ಇಸ್ ನಾಟ್ ಗೋಯಿಂಗ್ ಔಟ್, ಕರೆಕ್ಟಾ? ಸೊ ಇಫ್ more than 400 ml is remaining, then there is obstruction. If less than 400 ml is remaining, then it is normal. Okay, so gastric outlet obstruction diagnose ಆಯ್ತು. ಇವಾಗ we instilled 750 ml of saline and we asked the patient to sit for 30 minutes and we have aspirated it and there is more than 400 ml, so we have diagnosed it as gastric outlet obstruction. How will we manage this? We will keep the patient in NPO, nil per oral, for 48 hours. Yake, there is obstruction. If you give anything, nothing will pass out and it will come back. Okay, so ಅವನಿಗೆ ಏನು ಬೇಕು, ಊಟ ಕೊಡಬೇಕು, ನ್ಯೂಟ್ರಿಷನ್ ಎನರ್ಜಿ ಬೇಕು. ಫಾರ್ ದ್ಯಾಟ್ ವಿಲ್ ಗಿವ್ IV fluids ಥ್ರೂ ನಾರ್ಮಲ್ saline. And most patients will usually improve just by keeping the patient NPO and just by giving IV fluids. If the patient is not responding for this, we'll go for truncal vagotomy and antrectomy. Okay. If antrectomy becomes difficult, then we'll have to go for alternative treatment, that is truncal vagotomy and gastrojejunostomy, like joining gastric stomach and jejunum. Okay, so here imagine cause is duodenal ulcer, because we are speaking about duodenal ulcer and its complication. Okay na, so duodenal ulcer ಇಂದ ಆಗ್ತಾ ಇದೆ ಅಂತ ಹೇಳಿದ್ವಿ ಇದನ್ನ. Okay, so and we all know duodenal ulcer in the gastric perforation ಆದರೆ what we'll do, gastric outlet obstruction ಆದರೆ we'll go for truncal vagotomy to reduce. See, we are dealing with two causes here. ಒಂದು ಅಲ್ಸರ್ ಇದೆ, ಇನ್ನೊಂದು ಗ್ಯಾಸ್ಟ್ರಿಕ್ ಔಟ್ಲೆಟ್ ಅಬ್ಸ್ಟ್ರಕ್ಷನ್ ಇದೆ. ದಿಸ್ NPO ಇಟ್ಟಿದ್ದೀವಿ and we are giving IV fluids. Now we have to treat this also. For this, truncal vagotomy along with this antrectomy. So this will reduce all chances of acid production. Okay. Even after this, or if antrectomy becomes difficult, then we will go for truncal vagotomy and then we'll join the stomach with jejunum. ಇದು ಡುವೋಡೆನಮ್ ಇರುತ್ತೆ, ನೆಕ್ಸ್ಟ್ ಇಲ್ಲೆಲ್ಲ ಲೂಪ್ಸ್ ಇರೋದು ಜೆಜುನಮ್ದು. ಸೊ ಗ್ಯಾಸ್ಟ್ರೋಜೆಜುನೋಸ್ಟಮಿ. ಸೊ ಇಲ್ಲೆಲ್ಲ ಡುವೋಡೆನಮ್ಮಲ್ಲಿ ಎಲ್ಲ ಅಬ್ಸ್ಟ್ರಕ್ಷನ್ ಆಗಿರುತ್ತೆ ಬಿಕಾಸ್ ಆಫ್ ದಿಸ್ ಡುವೋಡೆನಲ್ ಅಲ್ಸರ್. ಸೊ ವಿ ಆರ್ ಬೈಪಾಸಿಂಗ್ ಡುವೋಡೆನಮ್ ಆ್ಯಂಡ್ ಕನೆಕ್ಟಿಂಗ್ ಗ್ಯಾಸ್ಟ್ರಿಕ್ ಸ್ಟಮಕ್ ಟು ಜೆಜುನಮ್. ಓಕೆನಾ? ಬೈ ದಿಸ್ we are able to relieve the obstruction. Okay, so that was the treatment for non-responding patients, truncal vagotomy and gastrojejunostomy. Okay, there are other treatments in which we can go for gastrectomy, and there are two types mainly. It was first performed by Theodore Billroth in 1881. Okay, there are two types of gastrectomy, that is Billroth gastrectomy and Billroth 1 and Billroth 2, and the third variety is Rowe-en-Y gastrojejunostomy. So what is the difference here? In Billroth 1 gastrectomy, it is also called as gastroduodenostomy. What we'll do is we'll take out some part of stomach and we'll connect it with duodenum. Okay, this is gastroduodenostomy or Billroth 1 gastrectomy. In Billroth 2, it is also called as loop gastrojejunostomy. Okay, ಸೊ ಇಲ್ಲಿ ಡುವೋಡೆನಮ್ನ ಹಾಗೆ ಪ್ರಿಸರ್ವ್ ಮಾಡಿ ಅದನ್ನು ಕನೆಕ್ಟ್ ಮಾಡ್ತಿದ್ವಿ. ಇಲ್ಲಿ ಡುವೋಡೆನಮ್ ಕೂಡ ತೆಗಿತೀವಿ. ಸಮ್ ಪಾರ್ಟ್ ಆಫ್ ಸ್ಟಮಕ್ ಆ್ಯಂಡ್ ಡುವೋಡೆನಮ್ ಇಸ್ ರಿಮೂವ್ಡ್ ಆ್ಯಂಡ್ we are connecting the remaining part of the stomach with jejunum. Here there are maximum risk of complications, whereas in Billroth 1, since duodenum is preserved, there are less risk of complications. So types of gastrectomy based on amount of stomach removed. Total gastrectomy ಅಂದರೆ entire stomach is removed. Near total ಅಂದರೆ about 90%. Subtotal ಅಂದರೆ about 80 to 90%. Partial gastrectomy ಅಂದರೆ about 65 to 75%. Hemigastrectomy ಅಂದರೆ about 50% is removed. Antrectomy is only 35%, that is distal gastrectomy. Okay na? So distal gastrectomy ಅಲ್ಲಿ this part of the stomach is removed. Whatever the part is shown in silver color or whatever I am highlighting now, that is distal gastrectomy. Subtotal ಅಂದರೆ almost 80 to 90% of the stomach is removed. And here total gastrectomy, almost about 90% is removed, remaining only just to cardia and pylorus part is left out. Okay, these are all just other treatment for duodenal ulcers or gastric outlet obstruction. Okay, so we have discussed about peptic ulcers totally, and now there is certain part remaining, which is what is the complications of gastrectomy. Yeah, ಕಾಂಪ್ಲಿಕೇಶನ್ಸ್ ಆಫ್ ಗ್ಯಾಸ್ಟ್ರೆಕ್ಟಮಿ ಏನಾಗುತ್ತೆ, ಸೆಕೆಂಡರಿ ಟು ಗ್ಯಾಸ್ಟ್ರಿಕ್ ರಿಸೆಕ್ಷನ್ ಆಯಿತಾ. ಅಂದರೆ ಇವಾಗ ಸ್ಟೊಮಕ್ನ ತೆಗೆದಾಕ್ತೀವಿ ನಾವು, ಅದಾದಮೇಲೆ ಸ್ಟೊಮಕ್ ತೆಗೆಯೋದ್ರಿಂದ ಏನಾದರೂ ಒಂದಷ್ಟು ಕಾಂಪ್ಲಿಕೇಶನ್ಸ್ ಆಗುತ್ತೆ. ಅದು ಆ ಕಾಂಪ್ಲಿಕೇಶನ್ಸ್ ಏನಂದರೆ, ಒನ್ ಈಸ್ ಡಂಪಿಂಗ್ ಸಿಂಡ್ರೋಮ್, ಅದರ್ ಒನ್ ಈಸ್ ಮೆಟಬಾಲಿಕ್ ಡಿಸ್ಟರ್ಬೆನ್ಸಸ್. ಓಕೆ, ಆ್ಯಂಡ್ ದೆನ್ ಇಫ್ we leave it only, we'll remove the stomach, or because of removal of stomach we are having these two, and because of reconstruction, that is we are either doing gastro duodenostomy, ಕರೆಕ್ಟಾ, ಅಂದರೆ ಡುವೋಡನಮಿಗೆ ಕನೆಕ್ಟ್ ಮಾಡ್ತಿದ್ದೀವಿ, ಆರ್ ಗ್ಯಾಸ್ಟ್ರೋ ಜೆಜುನಾಸ್ಟಮಿ. We are not just removing stomach, but we are connecting it to something else. We are doing reconstruction. Because of that reconstruction, some complications might occur. What are they? That is afferent loop syndrome, efferent loop obstruction, alkaline reflux gastritis, or retained antrum syndrome. So we'll go one by one, and then we are doing vagotomy also. Because of that, there can be post-vagotomy diarrhea, post-vagotomy gastric atony, or incomplete vagal transection. So these are the complications which can occur during gastrectomy. Okay, so what is the function of stomach? Basically, it is a temporary storage of foodstuff, and it is converting whatever the hyperosmolar content is coming into the stomach, that is converted into isoosmolar content. Okay, so what is dumping syndrome actually? It is constellation of symptoms due to accelerated emptying or dumping of hyperosmolar content into proximal part of the small intestine. So basically ಇಲ್ಲಿ ಏನಾಗ್ತದೆ ಹೇಳ್ತೀನಿ. ಈಸೋಫೆಗಸ್ ಆಯಿತಾ, ಅಲ್ಲಿಂದ ಸ್ಟೊಮಕ್ ಸ್ಟಾರ್ಟ್ ಆಗುತ್ತೆ. ದಿಸ್ ಇಸ್ ಕಾರ್ಡಿಯಾ ಆ್ಯಂಡ್ ದೆನ್ ಡುವೋಡೆನಮ್. ಓಕೆ, ಆ್ಯಸ್ ವಿ ಆಲ್ ನೋ, ಈಸೋಫೆಗಸ್ ಇಸ್ ಜಸ್ಟ್ ಫುಡ್ ಪೈಪ್. ಓರಲ್ ಕ್ಯಾವಿಟಿಯಿಂದ ಏನೇನು ಫುಡ್ ತೊಗೊಳ್ತೀವಿ, ಎವ್ರಿಥಿಂಗ್ ವಿಲ್ ಕಮ್ ಹಿಯರ್ ಆ್ಯಂಡ್ ಇಟ್ ಈಸ್ ಡಂಪ್ಡ್ ಇನ್ ಟು ಸ್ಟೊಮಕ್, ವೇರ್ ಆ್ಯಕ್ಚುಯಲ್ ಡೈಜೆಷನ್ ಆ್ಯಂಡ್ ಆಲ್ ಹ್ಯಾಪನ್ಸ್. ಆ್ಯಂಡ್ ಹಿಯರ್ ಯೂಶಲಿ ದ ಫುಡ್ ಸ್ಟೇಸ್ ಫಾರ್ 2 hours to 3 hours and digestion occurs. But we have done gastrectomy. Okay, we have removed the stomach. So now esophagus is connecting to duodenum, because of which there will be this time, whatever was there, that is removed now. So food directly from the intestine comes to duodenum, because of which there is accelerated emptying, and this food, whatever was we were taking, they are hyperosmolar. Hyperosmolar ಅಂದರೆ there is no water in, basically water ಇಲ್ಲ ಅಂತ ಅಂದ್ಕೊಳ್ಳಿ, it is like solid ಆಯಿತಾ. decreased water content is there, and once it enters the stomach, there it will become isoosmolar because of acid and all other mechanisms, like all other enzymes will convert it into isoosmolar. Okay, since here no stomach is there, whatever the hyperosmolar content is there, that is directly entering into proximal part of the intestine, small intestine, that is duodenum. In case of Billroth 1, duodenum, and in case of Billroth 2, it is jejunum directly. Okay, so because of this, it is called as dumping syndrome. ಇದರಲ್ಲಿ ಏನಾಗುತ್ತೆ ಹಂಗಾದರೆ ಡಂಪಿಂಗ್ ಸಿಂಡ್ರೋಮಲ್ಲಿ? ವಾಟ್ ಆಯ್ತು, ಇವಾಗ ಆಕ್ಸಲರೇಟೆಡ್ ಎಂಪ್ಟಿಂಗಿಂದ ಏನು ಪ್ರಾಬ್ಲಮ್ ಆಗುತ್ತೆ? ಸೊ ಹಿಯರ್ ಅರ್ಲಿ ಡಂಪಿಂಗ್ ಸಿಂಡ್ರೋಮ್ ಅಂದ್ರೇನು? ಇಟ್ ಈಸ್ ಲೈಕ್ ಬೇಸಿಕಲಿ ಏನಾಗುತ್ತೆ ಇವಾಗ, ದೇರ್ ಎವ್ರಿ ಲೈಕ್ ಹೈಪರ್ ಆಸ್ಮೋಲಾರ್ ಕಂಟೆಂಟ್ನ ಸೀದಾ ಇಂಟೆಸ್ಟೈನಿಗೆ ಹಾಕಿದರೆ ಇಟ್ ವಿಲ್ ಸ್ಟಾರ್ಟ್ ಡ್ರೈನಿಂಗ್ ವಾಟರ್ ಫ್ರಮ್ ಅವರ್ ಬಾಡಿ, ಬಿಕಾಸ್ ಆಫ್ ವಿಚ್ ದೆರ್ ವಿಲ್ ಬಿ ಸೀರೀಸ್ ಆಫ್ ಇವೆಂಟ್ಸ್. ಹೈಪೋವೊಲಿಮಿಯಾ ಆಗ್ಬೋದು, ಡಿಸೆಲೆಕ್ಟ್ರೋಲೈಟಿಮಿಯಾ ಆಗ್ಬೋದು, ಎವ್ರಿ ಇಶ್ಯೂ ವಿಲ್ ಹ್ಯಾಪನ್. ಓಕೆ, ಸೊ ಅದನ್ನೇ ಇಲ್ಲಿ ಎಕ್ಸ್ಪ್ಲೇನ್ ಮಾಡ್ತಿದ್ದಾರೆ. ಅರ್ಲಿ ಡಂಪಿಂಗ್ ಈಸ್ ಸೀನ್ ವಿತಿನ್ 15 to 30 minutes of meals. Here hyperosmolar content is passing on to jejunum, which will increase secretions in jejunum because it is hyperosmolar. Then there will be water loss or third space loss, because our body, like this food is draining water from our body itself. So from our body, if it is draining, it is similar to hypovolemia, basically hypovolemic shock. ಇವಾಗ ಆಕ್ಸಿಡೆಂಟ್ ಆಗಿ ಬ್ಲಡ್ ಲಾಸ್ ಆದರೆ ಯಾವ ಫಿನಾಮಿನಾ ಆಗುತ್ತೆ, ಅದೇ ಫಿನಾಮಿನಾ ಇಲ್ಲಿ ಜಸ್ಟ್ ನಾವು ಫುಡ್ ತಿನ್ನೋದ್ರಿಂದ ಆಗ್ತಾ ಇದೆ. Okay, because of which there will be hypovolemic shock like symptoms, and then he can go for congestive heart failure also. So it can be that dangerous. Okay, so what is the treatment? Basically we know there is hypovolemia. So what is the treatment for hypovolemia? Give fluids, give volume, fluid volume. So hypovolemia treatment IV fluids. If late dumping is seen, it is usually seen after 2 to 3 hours of meals. Okay, illénagutte hyperosmotic or hyperglycemic content is in jejunum, and there is increased release of insulin. Okay, which leads to reactive hypoglycemia leading to late dumping. So here what we have to do, we have to treat it with glucose, because insulin is there, glucose is not there. Okay, so illénagutte, there will be increased glucose content in jejunum, because of which increased release of insulin. And this will lead to ಲೈಕ್ ಇಷ್ಟು ಗ್ಲೂಕೋಸಿಗೆ ಎಷ್ಟು ಇನ್ಸುಲಿನ್ ಬೇಕಿತ್ತೋ ಅದಕ್ಕಿಂತ ಜಾಸ್ತಿ ರಿಲೀಸ್ ಆಗಿಬಿಡುತ್ತೆ. ಸೊ ಇವಾಗ ಗ್ಲೂಕೋಸ್ ಕಮ್ಮಿ ಆಯಿತು, ವಿಚ್ ವಿಲ್ ಬಿ ಮ್ಯಾನಿಫೆಸ್ಟಿಂಗ್ ಲೈಕ್ ಹೈಪೋಗ್ಲೈಸಿಮಿಯಾ. ಪೇಷಂಟ್ ಮೇ ಕೊಲ್ಯಾಪ್ಸ್, ಬಿಕಮ್ ಅನ್ಕಾನ್ಷಿಯಸ್, he will have sweating, everything. ಓಕೆನಾ, ಹೈಪೋಗ್ಲೈಸಿಮಿಯಾ ಮ್ಯಾನಿಫೆಸ್ಟೇಷನ್ಸ್ ಶುರು ಆಗುತ್ತೆ. ಸೊ ಇಮಿಡಿಯೇಟ್ಲಿ ವಿ ನೀಡ್ ಟು ಗಿವ್ ಹಿಮ್ ವಿತ್ ಮೋರ್ ಗ್ಲೂಕೋಸ್. ಸೊ ದಿಸ್ ಈಸ್ ಅಬೌಟ್ ಡಂಪಿಂಗ್ ಸಿಂಡ್ರೋಮ್. ಸೊ ಪ್ರಿವೆನ್ಷನ್ ಹೆಂಗೆ ಮಾಡ್ಬೋದು ಇದನ್ನು? ನಮಗೆ ಗೊತ್ತು ಗ್ಯಾಸ್ಟ್ರೆಕ್ಟಮಿ ಮಾಡೋದ್ರಿಂದ ಡಂಪಿಂಗ್ ಸಿಂಡ್ರೋಮ್ ಆಗುತ್ತೆ ಅಂತ. ಹೌ ಕ್ಯಾನ್ ವಿ ಪ್ರಿವೆಂಟ್ ಡಂಪಿಂಗ್ ಸಿಂಡ್ರೋಮ್? ವಿ ಕ್ಯಾನ್ ಗೋ ಫಾರ್ ಡಯಟ್ರಿ ಮಾಡಿಫಿಕೇಷನ್ಸ್. ಸ್ಮಾಲ್ ಫ್ರೀಕ್ವೆಂಟ್ ಮೀಲ್ಸ್ ತೊಗೊಳಪ್ಪ ಅಂತ ಹೇಳ್ಬೋದು. ಒಂದೇ ಸಲ ಜಾಸ್ತಿ ತೊಗೋಬೇಡ, ಅವಾಗ ಹೈಪರ್ಗ್ಲೈಸಿಮಿಕ್ ಕಂಟೆಂಟ್ ಜಾಸ್ತಿ ಆಗುತ್ತೆ, ಆರ್ ಹೈಪೋರಾಸ್ಮೋಲಾರ್ ಕಂಟೆಂಟ್ ಜಾಸ್ತಿ ಆಗುತ್ತೆ, ಬಿಕಾಸ್ ಆಫ್ ವಿಚ್ ಇಟ್ ಕ್ಯಾನ್ ಗೋ ಫಾರ್ ಹೈಪೋಲಿಮಿಯಾ ಆ್ಯಂಡ್ ಇಟ್ ಕ್ಯಾನ್ ಗೋ ಫಾರ್ reactive hypoglycemia. So take small and frequent meals, give your body time to adjust. Okay, low carbohydrate, high fat, high protein diet. Carbohydrates is the first to get absorbed. So low carbohydrates, high fat and high protein kodadrinda ಏನಾಗುತ್ತೆ, it will take time for digestion and it will prevent dumping syndrome. Okay, avoid high calorie drink and avoid liquids during meals, because liquids directly pass into the duodenum, ಆಯಿತಾ, whereas solid foods will buy time. Okay, if the patient is not improving after dietary modification, we will have to give him octreotide, okay, which is a somatostatin analog, which will decrease secretions of GIT and it will also decrease insulin release. ಓಕೆನಾ, ನಮಗೆ ಇಲ್ಲಿ ಆಗ್ತಿರೋದು ಎರಡು ಪ್ರಾಬ್ಲಮ್. ಒಂದು, ಇನ್ಕ್ರೀಸ್ಡ್ ಸೆಕ್ರೇಷನ್ಸ್ ಆಗ್ತಿದೆ, ಬಿಕಾಸ್ ಆಫ್ ದ್ಯಾಟ್ ಸೆಕ್ರೇಷನ್ ದೆರ್ ವಿಲ್ ಬಿ ಥರ್ಡ್ ಸ್ಪೇಸ್ ಲಾಸ್, ಆ್ಯಂಡ್ ಬಿಕಾಸ್ ಆಫ್ ದ್ಯಾಟ್ ದೆರ್ ವಿಲ್ ಬಿ ಹೈಪೋವೆಲಿಮಿಯಾ. ಸೊ ವಿ ಹ್ಯಾವ್ ಟು ಡಿಕ್ರೀಸ್ ಸೆಕ್ರೇಷನ್ಸ್ ಆಫ್ ದ ಗಟ್. For that, we'll give octreotide. And again, late dumping syndrome is because of increased insulin release. In order to reduce, again, we'll have to go for somatostatin analog. So octreotide will serve both purposes. If the patient is still not improving after octreotide also, then we'll have to go for surgery. That is, if we have done Billroth 2, we'll have to go for Billroth 1. That is, duodenumನ ಕೂಡ ರಿಮೂವ್ ಮಾಡಬೇಕಾಗುತ್ತೆ, ಗ್ಯಾಸ್ಟ್ರೋ ಡುodenostomy ಮಾಡಬೇಕು. So usually dumping syndrome is more commonly seen in Billroth 2 and it is less seen in Billroth 1. ಆಯಿತಾ, ಅದಕ್ಕೆ Billroth 2 ಮಾಡಿದರೆ ಯೂಶಲಿ ಡಂಪಿಂಗ್ ಸಿಂಡ್ರೋಮ್ ಆಗುತ್ತೆ, ಅವಾಗ Billroth 1ಗೆ ಕನ್ವರ್ಟ್ ಮಾಡ್ಬೋದು. ಇಲ್ಲಾಂದರೆ ಇಂಟರ್ಪೊಸಿಷನ್ ಆಫ್ ಆ್ಯಂಟಿ ಪೆರಿಸ್ಟಾಲ್ಟಿಕ್ ಸೆಗ್ಮೆಂಟ್ ಆಫ್ ಜೆಜುನಮ್. ಸೊ ಇವಾಗ ಯೂಶಲಿ ಪೆರಿಸ್ಟಾಲ್ಸಿಸ್ ಅಕರ್ ಇನ್ ಯೂನಿಡೈರೆಕ್ಷನ್. ಸೊ ಸ್ಟೊಮಕ್, ಡುodenum, ಅಲ್ಲಿಂದ ಜೆಜುನಮ್, ಹೀಗೆ ಹೋಗ್ತಾ ಇರುತ್ತೆ ಪೆರಿಸ್ಟಾಲ್ಸಿಸ್. ಸೊ ಇವಾಗ ಏನು ಮಾಡ್ತಾರೆ, ಆ ಪಾರ್ಟ್ ಆಫ್ ಜೆಜುನಮ್ ಈಸ್ ಟೇಕನ್, ಆಯಿತಾ, ಇದು ಹಿಂಗಿರೋದನ್ನು ಉಲ್ಟಾ ಮಾಡಿಬಿಟ್ಟು ದೆಲ್ ರಿವರ್ಸ್ ಇಟ್ ಆ್ಯಂಡ್ ಇನ್ಸರ್ಟ್ ಸಮ್ವೇರ್. ಸೊ ಆ್ಯಂಟಿ ಪೆರಿಸ್ಟಾಲ್ಟಿಕ್ ಸೆಗ್ಮೆಂಟ್ನ ಇನ್ಸ್ಟಾಲ್ ಮಾಡ್ದಂಗೆ. ಬೇಸಿಕಲಿ ಹೆಂಗೆ ಬೈಪಾಸ್ ಗ್ರಾಫ್ಟಲ್ಲಿ ವೈನ್ ತೊಗೊಂಡು ಅದನ್ನು ಉಲ್ಟಾ ಮಾಡಿ ವೈನಲ್ಲಿ ವ್ಯಾಲ್ವ್ಸ್ ಇರುತ್ತೆ ಅಂತ ಅದನ್ನು ಇನ್ಸರ್ಟ್ ಮಾಡ್ತೀವಲ್ಲ ಬೈಪಾಸ್ ಗ್ರಾಫ್ಟಿಂಗಲ್ಲಿ, ಅದೇ ಥರ ಒನ್ ಆ್ಯಂಟಿ ಪೆರಿಸ್ಟಾಲ್ಟಿಕ್ ಸೆಗ್ಮೆಂಟ್ ಆಫ್ ಜೆಜುನಮ್ ಇಸ್ ಟೇಕನ್ ಆ್ಯಂಡ್ ಇಟ್ ಈಸ್ ಇಂಟರ್ಪೊಸಿಷನ್. ಓಕೆ, ಸೊ ದಿಸ್ ವಿಲ್ ಸರ್ವ್ ಇನ್ delaying the peristalsis and hence it will buy time for digestion. Okay, so this was about dumping syndrome. What are the metabolic complications? That is, most common metabolic complication is iron deficiency anemia, because orally we will consume iron as Fe3+, that is in ferric form, and because of this stomach acid whatever was there, that was converting ferric to ferrous and this was absorbable. But now we have removed the stomach, so whatever the ferric is there, that will remain as ferric only, and because of which iron will not be absorbed, and because of that patient will be having iron deficiency anemia over time. So we'll have to go for increased oral supplementation. Okay, so megaloblastic anemia might also happen, because I told you if more than 50% of the stomach is removed, that is intrinsic factor secretion agalla. If this intrinsic factor is there, then if this intrinsic factor is absent, then vitamin B12 will not be absorbed. If vitamin B12 is not absorbed, that will lead to megaloblastic anemia. And in treat ಮಾಡಬೇಕಾಗುತ್ತೆ, we'll have to treat him by lifelong parenteral supplementation of vitamin B12. Okay, so this was about part 1 of stomach. Basically we have discussed about peptic ulcer diseases. ಓಕೆನಾ, ಅದರಲ್ಲಿ ಮೇಯ್ನ್ಲಿ ಸರ್ಜಿಕಲ್ ಸೈಡ್ಗೆ ಇದ್ದೀನಿ ನಾನು. ಲೈಕ್ ಮೆಡಿಕಲ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್ ವಿ ಆಲ್ ನೋ, ಲೈಕ್ ಆ್ಯಂಟಾಸಿಡ್ಸ್, ಗ್ಯಾಸ್ಟ್ರಿಕ್ ಪ್ರೋಟಾನ್ ಪಂಪ್ ಇನಿಬಿಟರ್ಸ್ ಕೊಡೋದು, H2 ಬ್ಲಾಕರ್ಸ್ ಕೊಡೋದು, ಇದೆಲ್ಲ ಮಾಡ್ತಾರೆ. ಬಟ್ ಪೆಪ್ಟಿಕ್ ಅಲ್ಸರ್ಗೆ ಸರ್ಜಿಕಲಿ ಏನು ಟ್ರೀಟ್ಮೆಂಟ್ ಆಗುತ್ತೆ, ದ್ಯಾಟ್ ವಿ ಹ್ಯಾವ್ ಡಿಸ್ಕಸ್ಡ್. ಓಕೆ, ಇಫ್ ಐ ಹ್ಯಾವ್ ಟು ರೀಕ್ಯಾಪ್, so peptic ulcer diseases involves two types of ulcers: gastric ulcer and duodenal ulcer. Okay, so gastric ulcer is classified based on modified Johnson's classification, and in that there are 4 types, I mean 5 types: type 1, 2, 3, 4 and 5. 5 is NSAID induced ulcer, and for that we all know, just stop NSAIDs and ulcer will cure. Type 1 is, it is present in incisura angularis, that is most common notch along the lesser curvature. And in type 2 there are 2 ulcers, one in the antrum and one in the pylorus region. In type 3 that is prepyloric. Type 4 it is most commonly in the antrum. And type 5 is NSAID based. Okay, based on this we'll start treating. In type 2 and type 3 there will be increased acid production, and hence we'll go for vagotomy, truncal vagotomy. Whereas in type 1, 4 and 5 there will be usually HCl will be normal only, so for this treatment is different. Okay, then duodenal ulcers we have discussed. These are treated based on complications. So what are the complications? It can be intractable, it can be leading to bleeding, or there can be gastric outlet obstruction, or there can be perforation. If the duodenal ulcer is intractable, then we'll go for high selective vagotomy or truncal vagotomy. ಆಯಿತಾ? ಬ್ಲೀಡಿಂಗ್ ಇದ್ದರೆ ಏನು ಮಾಡ್ತೀವಿ? ವಿ ಸ್ಟಡಿಡ್. ಬ್ಲೀಡಿಂಗ್ ಇದ್ದರೆ ವಿಲ್ ಹ್ಯಾವ್ ಟು ಮ್ಯಾನೇಜ್ 2 things. One is bleed, we'll go for duodenostomy and we'll see the ligating vessel and we'll ligate it, and then we'll come for truncal vagotomy along with that. For duodenal ulcer we'll go for truncal vagotomy. Gastric outlet obstruction idre we have studied whole lot of things like gastrectomy, that is Billroth procedures, and then ಓದಿದ್ವಿ ಗ್ಯಾಸ್ಟ್ರಿಕ್ ಔಟ್ಲೆಟ್ ಅಬ್ಸ್ಟ್ರಕ್ಷನ್ ರಿಲೇಟೆಡ್. ಬೇಸಿಕಲಿ ಗ್ಯಾಸ್ಟ್ರಿಕ್ ಔಟ್ಲೆಟ್ ಅಬ್ಸ್ಟ್ರಕ್ಷನ್ ಪ್ಯಾಥಾಲಜಿ ಓದಿದ್ವಿ, ಅದಾದಮೇಲೆ ಅದರ ಮ್ಯಾನೇಜ್ಮೆಂಟ್ ಓದಿದ್ವಿ. ಆಫ್ಟರ್ ದಿಸ್ ಪರ್ಫೋರೇಷನ್ ಇದ್ದರೆ ಬೇಸಿಕಲಿ ಗ್ರಾಹಮ್ಸ್ ರಿಪೇರ್, ಮಾಡಿಫೈಡ್ ಗ್ರಾಹಮ್ಸ್ ರಿಪೇರ್, that is omental patch repair. One patch of omentum is taken and that will be used for sealing this perforation. Okay, ಇಷ್ಟೇ ಅಲ್ವಾ ಇವತ್ತು? So this covers part 1 of stomach. We'll start with start 2 tomorrow. ಏನಾದ್ರು ಡೌಟ್ಸ್ ಇದೆಯಾ?
ಓಕೆ.